results of these tests affect prognosis and treatment?
Currently, for the most part, we're treating myeloma patients in a similar fashion, except for some tweaking based on these quote-unquote high-risk features. So there are certain chromosome abnormalities that tell us that a patient has a higher chance of relapsing early, even if they get the standard of care treatment. So we try to enroll those patients into a clinical trial or have better optimization of their induction treatment and their maintenance strategy. So identifying these high-risk abnormalities is important because our treatment decisions may be modified to that patient's disease, or we might be able to get them to a clinical trial sooner than later.
Right. What is risk stratification and how is it used in patient care?
So risk stratification helps us identify people who are going to do well in terms of getting to a good response and maintaining that response, or maintaining, or being, progression-free or disease-free, versus those folks who may be relapsing sooner. And that's called risk stratification. So you are essentially identifying and dividing patients into two different buckets, saying, all right, I have to pay attention to this person a bit more because they can relapse sooner. So I'm going to be keeping an eye on their labs and such, much closely.
Mm-hmm. Let's talk about therapy for myeloma patients. How are low-risk patients treated?
So typically, the low or standard risk patients are treated with at least a 3-drug induction treatment at the time of diagnosis, or sometimes with 4 drugs if you combine an antibody treatment. There are various regimens, but the standard of care is at least 3 drugs. Then for patients who may be eligible for a stem cell transplant, they go on to receive an autologous stem cell transplant. Once they've recovered from the stem cell transplant, they go on to maintenance treatment. And the idea is that, the induction along with, stem cell transplant for those patients who are eligible gets patients to as deep a response as possible. And the concept of maintenance is you maintain them in that response and delay the disease from coming back.
Right. And then what about high-risk patients? How are they treated?
So for high-risk patients, we typically prefer using a 4-drug regimen, either daratumumab RVD or carfilzomib with Lendex or KRD as induction treatment for high-risk patients. After the stem cell transplant, most patients would continue both the lenalidomide as maintenance, along with a proteasome inhibitor. If patients had low or standard risk disease, they would only be getting lenalidomide as maintenance. So here, for high risk patients, you're adding a proteasome inhibitor.